through each puncture site. Visualization of the bright yellow dot of light shows that the rod is in the correct plane. If the light becomes dull or red, the rod must be withdrawn and then redirected more superficially. If the rod passes too deeply underneath the platysma muscle, this may result in recurrent or residual platysmal banding and a less than ideal result. In the worst case scenario, the rod could create an injury to deeper structures in the neck. Rod is then brought out through point D. It will then be pivoted, leaving the tip of the rod in the subcutaneous space, and the rod will be brought out through point E5. Of note, the sutures are not cut at this point. Suture rods are left intact and the sutures are tied together. And then the matrix is carried on anteriorly to place the trampoline platysmoplasty. This animation illustrates the tying of the knot at the point just 1 centimeter anterior to the incision site of the first suture consisting of the neck defining suture. It's important to throw the first throw either using a single throw or double throw surgeon's knot to set the tension at the neckline. With the neck defining suture, adequate tension is extremely important in order to obtain success of the procedure. If the suture is too tight, the patient will have an overcorrected neck and will feel a sense of tightening as he or she flexes the neck. If it is under tension, then there will not be any evident results and the patient will not be happy with the operation either. So the point at which you have the perfect amount of tension is when you have the neck extended and you throw the first throw of the suture and pull it and tighten it just to the point where you just see the first signs of visible tensioning of the skin. When you see this, you can go ahead and put the second throw in to lock your suture. It doesn't matter what type of knot you use to tie the matrix in place, whatever works best for you will work for the neck defining suture. So once again in review, you throw the first throw, which will set the tension, you observe the neck, and look for the point where there's just visible tensioning of the skin with the patient's neck extended. Once you've established the correct amount of tension, then you can go ahead and lock the knot by placing another throw. The first throw can either be a surgeon's knot double throw or just a single throw in a square knot, as in this application that you're seeing right now. I always throw another throw so that I have 3 throws of the knot to further secure the knot in this region prior to completing the remainder of the procedure by proceeding anteriorly and placing the trampoline platysmoplasty. The trampoline platysmoplasty is then placed after the neck defining suture. This illustrates the tape that is used and placed along the jawline. This is included in the iGuide surgical suture system. As you'll note, there are alternating lines and dots. These are stenciled out from a point extending anteriorly to a point posteriorly, just at the posterior aspect of the angle of the mandible. The reason there are alternating lines and dots is that during the weaving of the suture matrix, this allows the surgeon to go to every other dot just as you would if you were lacing a shoe, one lace at a time. Usually in a woman with a normal sized mandible, 3 pivot points are used on each side. In a male with a larger jaw, 4 to 5 on each side. The marks underneath the jawline indicate pivot points where the rod is able to pivot as it travels underneath the jawline over the curved surface. These random dots allow the rod to pivot as it passes underneath the jawline. The puncture device is then used to make a puncture in each of the marked sites. It is rotated to the left and right 1/2 turn, thus dilating the puncture. These are the anchor puncture sites on the lateral ramus, where the suture will be weaved around the ligamentous attachments. The area underneath the jawline, these are called pivot points that allow the pivoting of the rod as it travels around the curved surface of the jawline underneath the mandible. The dermal attachments are then cleared using the clearing device, which is inserted in each puncture, and it is carefully rotated clockwise 2 to 3 turns, allowing the sweeping away of the dermal attachments. The sequence of each maneuver is just the same in the neck defining suture in order to create the surgical field and prepare it for the light guided suture rod. As the clearing device is inserted, is then rotated upwards so that it is perpendicular to the skin surface and is elevated. Some blanching can be seen where the tip of it is located as it is rotated clockwise 2 to 3 times. The matrix is then created by grasping one of the suture